Namaste and good evening, everyone. A very warm welcome to Breast Cancer Gynecology Cancer Management 2025. We are honored to have you join us for this webinar. We look forward to insightful discussion and meaningful learning this evening. With immense pleasure, I would like to invite Program Convener Dr. E. Prasad. He is a Senior Consultant Medical Oncology, Apollo Proton Cancer Center, Chennai. It's over to you, sir.
So welcome everybody to this guest lecture series on the breast cancer and the gynecological cancer management. We know that we had been doing a lot of new things which had completely changed the way of practice in the past couple of years. With this new treatment options available with monoclonal antibodies, targeted therapies, PARP inhibitors, we are evolving more into the therapeutics as well as the diagnostics. So gone are those days when we were treating everybody with chemotherapy. We choose whom we should give chemotherapy. And gone are those days when we have limited survival for ovarian cancer patients. Now the ovarian cancer patients with the HRD positive status live close to about 7+ years also. So a lot of things which had completely changed the way we look at these two common cancers, breast as well as the ovarian part of the gynecological malignancies. So today we do have eminent speakers with us from across India. I'll have the privilege of introducing the speakers and their topics, and then we can move on to the session. I'd like to invite Dr. Jayant Khandare, who is the scientist and the chief scientific officer and the co-founder in Actorius and Innovation Research Company. Welcome, sir. Good evening.
Thank you, Dr. Prasad. It's my privilege, our privilege, and good evening to everybody.
Most welcome. And this would be followed by our next speaker, who would be Dr. Arumugam, who is the professor and head of the medical oncology department at Tirunelveli Medical College. Dr. Arumugam, welcome, sir. And subsequently, it will be followed by the talk by Dr. Prasanna, who is the senior consultant and medical and hemato-oncologist of Apollo Specialty Hospital from Tiruchi. Welcome, Dr. Prasanna. Are you there?
Hi, Prasad. Good evening.
Welcome, Prasanna. Good evening. And our subsequent speakers would be Dr. Pandithurai, who is an associate professor in the Department of Medical Oncology at Raipeta Cancer Hospital, attached to Kilpak Medical College. Welcome, Dr. Pandithurai, sir. And the final speaker would be Dr. G. Raja, who is an associate professor from the Department of Medical Oncology, Kilpak Medical College, Raipeta Hospital. So thank you so much, all the speakers. So we do have a wonderful session for the next 1.5 to 2 hours. And we would first kickstart this session with Dr. Jayant Khandare's lecture on how do we evolve beyond the conventional diagnosis. We know we do have the CT scan and the PET CT scan, but do we have something beyond the scans is what Dr. Jayant is going to enlighten us about the role of circulating tumor cells, CTCs, in monitoring residual disease. So over to you, sir, and we are very eager to listen to you.
Thank you, Dr. Prasad. It's a pleasure to be here today and speak with eminent medical oncologist. And as a researcher with Actorius, me and Arvindan and Muthu have actually organized to share our circulating tumor cells technology, which is OncoDiscover, which is India's first medical device that has been approved by CDSC or DCGI, because innovations are complex and innovations require very strong regulatory path. And unfortunately, in India, innovations which have actually been translated from science to say bench to bedside have been not many examples. So I would like to actually state the role of circulating tumor cells, especially when they express PD-L1, and our own experiences in understanding their role in monitoring residual cellular disease, and more prominently, actually, its own distinguished role with and without DNA. I would like to share the data with about 11,000 patients. They have been actually predominantly been used in India and several other countries. Next slide, please. So I will have about 30 minutes or so, Dr. Prasad.
I have listened to your lecture earlier.
Uh-huh.
The time, sir.
Okay, right. So I'll try to cover this
very
in.
enlightening lecture. So I would like all of them not to listen. You can take your time to explain everything.
Okay, so I'll be very happy to actually be informed that when is my time, limited time. But I'll take about 30 minutes or so in sharing a story of Actoria's, who has actually a OncoDiscover, which is only DCJ approved technology. So what it takes to translate a technology from scientific ability to make it into the clinic. Most important, all of us know that the technologies which are actually developed in Western world probably undergoes very, very critical clinical evaluation. For oncologists, critical clinical decisions where actually you need a lot of information with guidelines, without guidelines, especially actually in a molecular genomics era, in a personalized era, in a precision oncology era. We started our journey, me and Arvindan, on the left-hand side in 2013 with taxpayers' fund from Department of Biotechnology. And if you look, this scale until 2025 is filled with immense patents, publications, our own abstracts in ASCO, AACR, International Society of Liquid Biopsy, ESMO, etc., covers almost more than 50 abstracts in last 7 to 8 years of a time. We also are an innovation technology company where we file patents, and these are all US patents that have been granted or ongoing examination. We only are a company currently who have actually reached to CDSU approval so far. And we also published oral cancer, uh, uh, the outcome of overall survival of using circulating tumor cells with Tata Memorial Hospital. Next slide, please. So what is important, I think, this statement which makes us quite uh, distressing, especially you are the oncologist. So I feel that what is more painful than a cancer relapse, and a cancer relapse not caught in a time. And I'll support this slide's catchy frame as we move from here. Next slide, please. So the content of presentation is actually what is the role of a circulating tumor cells. Very briefly, this is an executive summary that circulating tumor cells are live cells. They are the telltale signature of presence of a metastasis. Over all stages, stage 1 or multiple stages, and they have, when there is a primary tumor, there is an dissemination process, which is extravasation. And with lot of difficulties, these live cells, with their plasticity, with various transitions, including epithelial to mesenchymal and mesenchymal to epithelial, they come into the peripheral blood side, and from the primary side, they start seeding to cause a metastasis or micrometastasis by invading other distant organs. So I would like to mention that there is a difference between localized tumor versus metastatic tumors, but this is all driven through a systemic circulation. So I would like to say that there is a localized tumor, there is a disease in the systemic peripheral blood, which is quite often ignorant and cannot be evaluated unless there is a powerful, sensitive tool like OncoDiscover. And how does this systemically driven disease actually progresses into micrometastasis? That there's enough science to be spoken about. Many studies indicate role of a circulating tumor cells. And why do actually we get patients to come back if they were in the remission, especially in the breast cancer, ovarian cancer, or colorectal cancer? So remission to recurrence journey is actually transited by circulating tumor cells. Would like to also agree and disagree today that there would be no evidence of a disease by CT PET scan or MRI. It could be false negative or false positive. I will share actually my views about guidelines-based false negative as well as false positive using in CT PET scan with few examples. And when to use actually circulating tumor cells. Now, the era of PD-L1 in targeted therapy is very well known, but programmed death ligand protein overexpressing circulating tumor cells can evade the immune system. They can deactivate the T cells. Therefore, the CTCs which has cytokeratin protein along with the PD-L1 are most important to be actually monitored longitudinally. Presence of one circulating tumor cells with PD-L1 expression determines the outcome, and typically it would be a worst outcome even with an one circulating tumor cells in 7.5 ml or by our technology 1.5 ml. So we have defined a new term, me and Arvindan, to call as a minimal cellular residual disease, which is getting very popularized in liquid biopsy forums. They are trying to define difference between minimal residual disease using DNA and minimal cellular residual disease using circulating tumor cells. Can we actually predict, the presence of a disease post surgery, post chemotherapy, post radiation therapy, especially in the oral cancer or breast cancer, where with a curative intent, these patients, which patients are likely to come back or which patients would require chemotherapy and radiation therapy, along with all the stages, but predominantly focused into early stage cancers. So longitudinal monitoring remains most important if you really wish that your patients would have a better overall survival or progression-free survival. OncoDiscover CTC test is only with 1.5 ml of blood. This can be across all solid cancers, including actually we have a lot of data in sarcoma and other cancers. And therefore, detection of an early metastasis is scientific most challenging component that only circulating tumor cells technology can actually bring to your table. Next slide. So why did we start with the circulating tumor cells? Our Indian story of innovation began with this cancer circulation problem. This was a note that came in Science, journal Science in 2010. And when I was innovation head at one of a discovery company, I realized that as a chemist or chemical engineer or a biologist, I think this designing materials which has great chemical, physical, and biological property to capture those rare cells which are in low abundance in 1.5 ml of blood or per ml of blood, along with other billions of other cells, is extremely challenging, and therefore this was considered as a topmost challenging scientific problem for a chemist to create materials, engineer materials which can actually interact with those rare cells and capture specifically without false positive or false negative. However, all of us know that there is a lot of debate that if we find CTC, what do you do it? And that is what is a generation 1.0, where circulating tumor cells had a role in prediction of overall survival in breast, prostate, and colorectal cancer. And this technology was approved by US FDA with the brand name of a cell search in 2004. However, we also started with the similar utility or prognostication in solid cancers following cell search as an innovator. But since we have now 11,000 patient data in India and from other countries, including Turkey, Jordan, etc., we feel that CTC has actually important role, and this would be actually revolution 2.0. How I will actually disclose as we come into the next slides. Next slide, please. So I would like to have a very focused problem statement today. I know this is an breast and gynecological cancer evening seminars, but look at the accountability of DNA and CTC is actually more established both in adjuvant therapy, decision-making, de-escalation or escalation of a treatment. Uh, all oncologists know this, but I would like to ask a question today that in colorectal cancers, approximately 25% to 50% stage 2 and stage 3 cancer patients develop recurrence. And in spite of actually having a comprehensive treatment, and this is what is being spoken since 2010 or 2016. And in addition to CRC cancers, breast cancers also show actually recurrence in 30% of breast cancer cases, despite no evidence of disease by CT PET scan, and they relapse and they succumb after the treatment with curative intent. And we know that the disease in both these cancers, from colorectal or breast or lung cancer, might migrate to other organs, that includes liver. I have few cases which are actually cherry-picked, but they could be of an interest to community that we are talking about. So presence of both CTC distribution and ctDNA fragment can indicate actually the MRD or minimal cellular residual disease. And monitoring both of them in real time can probably give a better interventional outcome for your patients. Next slide. So I think extravasation, invasion, intravasation, and metastasis, this is what most of the time you might be looking to your patients when they come to the clinic. And I'm sure that in metastatic cancer patients, there is enough data that actually establishes to identify circulating tumor cells. But question number one, actually, if there are circulating tumor cells in metastatic cancer patient, what is its utility, clinical utility or role is actually a big challenge. But I would like to suggest that there is immense good science coming up now with multiple clinical trials, including a GREASE study, including something in dynamic study, or very recently as a miracle study. Next slide, please. So knowing this hypothesis that primary versus metastatic cancers, we know that 90% of cancer patients probably succumb under 5 years with a metastatic disease relapse in 90% of the patient. So more focus is actually given to metastatic patient treatment, but we know that about 10% of cancer patients might succumb with the primary tumors. And why this hypothesis is important, because I think exactly CTC can identify your patient in primary cancer patient, and I would like to have your thought process as we go on. Next slide, please. So Dr. Klaus Pantel, who coined the term along with Dr. Catherine Penarbius long time back, that when circulating tumor cells is present in a patient, that is called as a liquid biopsy. Now, liquid biopsy definition has gone to other blood-based biomarkers, and Dr. Klaus Pantel is our good advisor, scientific advisor, and he has actually this wonderfully designed X and Y axis with a time in years, with a tumor load in number of actually cells that can be actually detected while there is a local therapy with or without a neoadjuvant therapy. There's also minimal residual disease in the center point with an adjunct or post-adjunct therapy, which could be an occult disease if there is a presence of ctDNA as well as CTC. However, the technologies have actually, issue for their analytical as well as standardization. And all of us know that accessibility, availability, and affordability of such kind of technologies are not in India. So Actorius has made actually its presence to bring this kind of a technologies which can be also affordable, and they can also be in your therapies, including systemic therapy, when patient actually relapse. But in my opinion, when patient is called to be a cure, I think is there a possibility of these biomarkers? I'm going to present with some of the distinguished cases. So there are three important problems as a scientist I would like to understand from you in cancer, that there is an MDR, there's a cancer dormancy. This is very true for the disseminated tumor cells, especially in ER, PR, or hormone positive, or HER2 positive, or even in triple negative breast cancer patient. Depending upon an kind of a disease and the stage, we know the outcomes could be worse. But cancer tumor cells can be dormant for from months to decades in patient's body unless the immune system actually recognize them and evade these cells. So there is a minimal residual disease. I think we have spoken about the MRD, and as the time progresses, the technologies would be more sensitive to find out this MRD or MCRD. Next slide, please. Next slide. So when circulating tumor cells migrate from primary tumor to distant organ, that is what is the process of micrometastasis, which goes unrecognized. But we also have a technology in the form of an oncodiscovery, which can also capture both circulating tumor cells as well as CTC clusters. We find about 2% of patients has this kind of a CTC clusters, which defines very aggressive disease in those patients. Next slide, please. So why it is challenging to detect CTCs? Because 1 ml of a blood epithelial cancer patient might have billions of other cells, along with that very, very few circulating tumor cells. So to qualify circulating tumor cells, ideally you should capture with an affinity antibody like EpCAM, epithelial cell adhesion molecule antibody, or cadherin or other antibodies. But most validated affinity that is known and recognized and used for an approval by cell search is anti-EpCAM antibody. So after we capture a CTCs using our kit, we look for the cytokeratin protein presence with PDL1 positive or HER2 positive or EGFR positive or even ERPR positive with DAPI, and we merge all the stains to qualify whether there is a definitive CTC in the patient's blood. Next slide, please. So I think this, all of you know that the role of a biomarkers in precision oncology era can be as a liquid biopsy in early stage to metastatic disease with minimal residual disease, along with adjuvant therapy, post-surgery, pre-surgery, as a baseline numbers can be accounted. So if we if we try to take a patient blood sample before the surgery and after surgery with a confirmative disease, especially in the late stage or in mid stage, there's a possibility of actually enhancement of a circulating tumor cells, because with a resection, the tissue is actually more open with a lymphatic drainage, and there are many studies to prove that post surgery the CTCs number will be high. But depending upon various phenotypical and genotypical characteristics of CTCs, we can actually look for the early signature for this patient for the early recurrence. And I think that is where is the gap where, systemically patients are not evaluated for the presence of a CTCs. Next slide, please. So there's a very interesting review that has been published by Cohen et al. There are 3 possible scenarios as a dynamic changes using these biomarkers following treatment. All of us know that the primary resistance is a very common observation in your patient, and ctDNA as well as CTC can be evaluated. There's a second scenario where patient's DNA number fragments could go down, and you could monitor along with the time, and the patient would actually recur, where DNA numbers would be very high. The best case scenario and most favorable is actually the patient would have these kind of a biomarkers, and that biomarker will drop down and the patient would be remission. Ideally, this number in our observation would be less than 10%. Now, if you look at a clinical trial, BREED 1, 2, and -158 was a phase 2 multicenter randomized trial in 196 triple negative breast cancer patients. So it was very, very clear outcome for an overall survival, percentage of an overall survival, that when both the biomarkers are actually negative, there could be a best overall survival. Our own data of survival analysis in oral squamous cell carcinoma with Dr. Kumar Prabhash and Pankaj Chaturvedi also indicated the cut line for circulating tumor cells for survival probability on y-axis in 152 patients that was published 3 years before. Next slide, please. We have been actually challenged by most of the oncologists for the role of CTC as the science and the clinical trial data is coming forward. But most of the clinical trial designed with the primary objectives are limited for one type of a cancer or late stage of a cancer, which is actually important. But what we are challenged by Dr. Pankaj and Kumar Prabhat that uh, can we find CTCs in patients who are actually a very, very early stage or in a disease-free cancer patient, especially with few of the clinico-pathological indications like extranodal extension or perinuclear invasion. And this study showed that in Indian patients, that CTC can be a good diagnostic biomarker to identify which patients would actually come back, revert with a recurrence, and if they recur, actually why they recur. That has been actually shown in this publication. Next slide, please. So, as to sum up here at this point of a time, that we are first in class indigenously developed DCJ approved technology. There are about 450 oncologists in India and abroad have used our OncoDiscover test. Next slide. So, as I was mentioning, that conventional monitoring with curative intent surgery by PET can be often negative because the sensitivity of PET scan could be about 8 to 9 millimeter. So, are we considering, this as a false negative or false positive with presence and absence of the tumor? The liquid biopsy biomarkers are more progressive. They are going to be more sensitive because the size of a tumor cells typically could be 10 micron size, and the detection level of a PET scan is very, very high. And therefore, I think as right-hand side, curative intent surgery by liquid biopsy monitoring for no evidence of a disease, both pathological or radiological, could be better assessed by such kind of a biomarkers. Next slide, please. I'll show some of the data as we move on, but why cancer patients recur, especially in the lingering mysteries of a metastatic recurrence in breast cancer, was given into this wonderful paper, which was published in 2021, that the lag time for the detection of a CTC could be from 8 months to 36 months, as per as this study was established. And development of an overt medicine PET scan was actually accounted with this lag time in these cancer patients. Next slide, please. So why our technology is more sensitive today? Because the science of chemical engineering was actually advanced. We have a magnetic nanoparticle with multiple components with an antibody which has been conjugated. And on the right-hand side, if you see that using a fluorescence automated motorized microscope, we are able to see beautiful circulating tumor cells. Unfortunately, in this case, with CK18 positive or HER2 positive, and we can assess your patient for HER2 present or PD-L1 present for qualifying IO therapy or Herceptin, either to actually continue treatment or to stop to the treatment. We also supported many oncologists where you cannot have a biopsy, especially in gallbladder, cholangiocarcinoma, or xanthogranulites, where the information on this kind of a biomarkers is very, very low. In spite of having a PET scan positive, some of the oncologists decide not to treat patient if there was no CTC, or decide to treat them if there was a confirmatory CTC with a PD-L1 presence. Next slide, please. So this is what is a nutshell, that we do get actually patient blood sample. We have analyzed about 11,000 circulating tumor cells, 35,000 circulating tumor cells so far in about 11,000 cancer patients. Next slide. So we have been certified as a quality management system. Most of the studies, clinical studies, more than 550 patients were evaluated at Tata Memorial Hospital. We have a CDSU approved for a medical device to detect the circulating tumor cells. This is only company which has actually got an approval so far. And we are the second company in the world who has got any regulatory approval after US. Next slide, please. I would like to show some of the cases. What is our actually OncoDiscover test report? If you see on the left-hand side, amongst actually lot many leukocytes, which would have a nucleus, but they would not have a cytokeratin or PDL1 positive, finally is converted into a report with a CTC count, with a CTC cluster count and a PDL1 presence or ER/PR presence or HER2 present. In this particular case, we have been oncologist has been monitoring this patient when the patient was actually doubtful for the presence of actually micrometastasis. But within 3 months of a time post-surgery, the patient started showing circulating tumor cells. And as a favorable outcome, after third time point, the patient's probably immune system has taken out all the CTCs out. And this is a most favorable outcome kind of a report for the oncologist and for the patient. Next slide. So I would like to show cherry-picked cases. This might be, not very common, but in 2020, female 65 years with CA rectum CT3 and 2 patient came in March 2020 with NACT FOLFIRINOX 4 cycles. The patient had a surgery, Capox 4 cycles were actually given. Patient didn't had any sign of presence of a tumor at a locorenal site. However, this oncologist thought, is this actually confirmative? Because there might be a possibility that the patient would have actually a micrometastasis elsewhere. Having that doubt, he sent the blood sample. We found 2 cells in 1.5 ml. Unfortunately, in this patient, this doctor actually tweeted this case. Many of an oncologists said, why did you wanted to do a CTC test? But unfortunately for this patient, and fortunately for an oncologist, we could found 4 lesions into the liver. Patient was rushed during those COVID time to Tata Memorial Hospital for selective internal radiation therapy. We have published this case, and till last 6 months back, the patient was doing extremely good. So often you might want to have an intuitive decision to consider which patients would require a CTC test, especially in a breast cancer. If a patient is a TNBC at a very young age, I think the duration of an monitoring CTC could be shorter than that of an hormone positive patient. Or if you want to actually think second time whether you want to discontinue Herceptin, but if a patient has 2 time point with a negative CTC, you might have a chemo holiday for a few weeks if that is allowed by your guidelines. Similarly, on the right-hand side, the patient refused to do a surgery because of an age, female 80 years, by simple metronomical chemotherapy treatment, 3,000 rupees per month. We monitor this patient about 40 days in a consecutive duration with a response to treatment. And the decision of actually taking a surgery versus metronomical could have been very, very critical for this patient who refused to undergo the surgery. And sometimes I think this is very, very important for a medical oncologist or surgeon to take such kind of a decisions that which patient would require either the liver MRI or which patient could be saved based on their age from the surgery. Next slide. I'll try to actually come to the conclusions and our own data that this is a Jayant and Arvindan quadrant. We call this with little fun. In 519, our own patients' data, what it shows, it has a 4 probabilities as a quadrant. That if a patient had both CTC as well as DNA presence, the patient would be qualified high risk. This could be possible both in early stages as well as late stages. We don't want to qualify. We often disagree for stage 1 solid tissue biopsy determinant factor because there could be a -1, -2 TNM staging where patient cells progression of a cell proliferation cycle could be very aggressive. Even with a 10 to 100 cells in a division cycle might come into the blood circulation, and the progression of a metastasis could be even at those earlier stages. On the right-hand side, if you see, which is the second scenario, where DNA could be negative and CTC could be positive. And companies like Natera, they do actually ctDNA negative as a liquid biopsy test, following actually solid tissue as an agonist test for the confirmation for KRAS in colorectal cancer or PIK3 with breast cancer. And often when the DNA is negative, it is considered that there is no disease now. But we know that the presence of live circulating tumor cells is only caused to propagate the disease, not the DNA. DNA has a shorter half-life. CTC also has a shorter half-life. But now we know that 99% of CTC could be actually eliminated, where 1% of CTC could be very, very important to be monitored. The third case scenario on the left-hand side, bottom figure, you could see that ctDNA could be positive and CTC could be negative. This is a better situation when there was a surgery with a curative intent. However, if the margins were not completely taken off, you would find that DNA and the driver mutation. So for this quadrant 3, the patient is unlikely to progress with a metastasis, but might develop a loco-regional disease. On the best case scenario, where both the biomarkers are negative, and this number of absence of both the biomarkers, that number of percentage of patients is actually very, very low. Now, if you see the indication and the total patients in lung cancer, our own observation, that about 265 patients, the CTC positive were in 76% of a patient. Of course, the lung cancer patient, this was always a late stage cancer patient. But if you look on the other hand, in colon and breast cancer patient, more than 80% of the patients had actually presence of a CTC in spite of they were stage 1 or stage 2 or stage 3. So this indicates very clear cut that distinguishing patients, especially when they were early stage and younger, could be actually better monitored, and your chemotherapy or radiation therapy cycles could be actually enhanced based on the guidelines if they permit. Next slide. So I think very interestingly that we were not aware that Indian clinical practice consensus guidelines, which came in 2022, that analysis begin this consciousness management in oral cavity, following our 152 patient data. This publication by Dr. Kumar Prabhash and Pankaj Chaturvedi and many other authors included CTC as a biomarker into oral cavity cancers, naming specifically only DCJ approved test OncoDiscover in this publication. Next slide, please. I would like to sum up over here that OncoDiscover CTC test snapshot. What you see is actually, we are the strongest company in the world today to have live circulating tumor cells or CTCs in our bank for characterization with various proteins in understanding the disease progression. We have been supported by many oncologists, and I would want you to evaluate our technology, and especially actually in cancer stages where the patients are not metastasized, but actually likely to be metastasized, knowing actually other your conventional biomarkers. Next slide. So we do publish a lot, like you see in last year itself. I think we published four posters in ISLB, also in ESMO MAP, as well as in ESMO Berlin, and also ASCO 2024, 25, 23, and so on. Next slide. With 56 publications so far. Next slide, please. I would skip this slide for the time. Next slide, please. So I think we have, this would be my maybe a last slide before we come to the conclusion, that patients with ER/PR positive or negative, with HER2 positive or negative, with a liminal disease, and stage 1 and 2 could be analyzed at a baseline for CTC number. They could also be analyzed post-local after surgery, after 4 to 6 months of a time. You could also do an early systemic after completion of any adjuvant or chemotherapy before early endocrine therapy has been begun. That can be done after 6 to 8 months of a time, and so on in 12 months, and as a surveillance for this patient. And this is all reference into good publications in the literature. Next slide. But I'd like to conclude here. I think there's a conclusion slide. Can you go to hit 3 to 4 slides? Please go to the next slide. Next slide. Hit 3-4 times, please, and come to the conclusions. There's a good amount of work, a body of work for the PD-L1 presence on CTC, along with that of a solid tissue biopsy for IO therapy. Next slide. Go to the conclusion slide. Or anyway, thank you very much, and thank you for your attention and time. And it is a privilege to share our data. Dr. Prasad, over to you.
Thank you. That was quite a informative talk. We always wanted to learn something new, and oncology is something which gives us butterflies every day for every patient. So
Absolutely.
we come with some new question. Just wanted to have one question, if I may ask you.
Please.
So, for example, sir, in a stage 4 patient, wherein the guidelines says to continue the treatment till there is maximal response, or stop the treatment or change the treatment in case of any toxicity.
Right.
So in that situation, say for example, if I'm doing a CTC after getting a radiological complete response, and if I get a CTC nil and a ctDNA nil, am I justified to stop the treatment? If so, how many number of CTCs and ctDNAs should I repeat it on what time basis to justify to stop the treatment? If radiological CR, CTC, ctDNA nil.
I can mention, Dr. Prasad, this is the most defined exceptional question that I have been asked so far in hundreds of talks. So thank you for this, very selective. So when we say that negative PET scan, you would take this as a negative or no presence of a tumor, isn't it? So similarly, if you look at the sensitivity of a CTC with no CTC present, especially with the PD-L1, I can assure you in solid cancers, you could consider to test the patient with 2 time points for your double confirmation to stop or do a de-escalation or do a chemo holiday for this patient who has a toxicity. So having a no evidence of a disease by CT PET scan is your guidelines. I must admit that CTC is not guidelines-based analysis because it is still, in multiple clinical trials, and because of a lack of an availability and affordability, the clinical trial designs undergoes $100 million, especially in pancreatic in European Union status. So to answer your question, yes, if we have 2 time points, absolutely zero CTCs, it is a confirmative that there is no dissemination of a CTCs from the primary tumor, or there is no lurking disease, absolutely to reconfirm by the PET scan. But what I would like to mention, where your stage 4 patient who has a complete remission, right? Absolutely no sign of a proteins, no sign of any other biomarkers, especially in colorectal stage 3 cases. I would advise to do a CTC test. If you found even one CTC with the PD-L1, please go for an MRI to reconfirm that the patient doesn't have a lesions in the liver. Because we know that colorectal and breast cancer patients are likely to go to the liver. Brain is probably a possibility for the breast cancer patient. So in order to know which cancer patient would not like to have a brain cancer patient, negate out by the CTs. So did I answer your question or?
partly, sir, I would say. The sense, I had one patient who had a breast cancer, radiological CR. I've done a CTC, ctDNA, all were negative. Patient is only on maintenance trastuzumab. Not an
Right.
expensive test, HER2 positive, doing fine for almost like 4.5 years. And I do have another HER2 positive endometrial carcinoma, who's in the fifth year, again on the same trastuzumab, but for the endometrial carcinoma patient, radiologically CR, but CTC was positive, ctDNA was negative.
So this is absolutely fine because see the your CT PET scan could be negative and CTC is present. That means you have a minimal cellular residual disease, and that's exactly the utility of actually this kind of a biomarker. Say for example, DNA, you can get one single fragment of a DNA post surgery or even a complete response to the patient, complete CR patient. If there was one DNA, you could actually confirm whether there is a driver mutation in existence in the patient. Absence of a DNA, absolutely you have no localized tumor. But that doesn't mean patient does not have a disease in a systemic manner. The disease would be in the blood, it is in the circulation, and by pulling the blood sample, we'll be able to find out a zero or one cell. So the sensitivity of, I think the question that you wanted to ask probably to challenge ourselves, in oral cancer, we have shown ROC by about 92% sensitivity in oral cancers. In breast cancer, this could be about 94%. In lung cancer, this would be lesser. It would be like 82, 83% because for some reason, even in an late stage lung cancer patient, we might miss CTC because of a nature of a disease and the nature of an anatomy of actually lung tissue, which doesn't disseminate cells very easily. That's why the approval for the CTC in metastatic situation in 2004 was given in breast, colorectal, and prostate cancer. But now there's a lot of data in colorectal, prostate, other cancers, including RCC, including ovarian cancer. So every patient is unique. Every patient might be individualized. And I think this is what is the power of this kind of a technology. I would not suggest every patient for CTC. You have to have an intuitive power, capability, a doubt whether your patient would require this test or not. And my experience is that most of the oncologists, senior oncologists who would not believe in CTC, have started actually telling me that their patients are now completely in the remission when CTC is completely absent at least 2 time points.
Yeah, right. I mean, I've also started believing in the CTC and ctDNA after your previous lecture.
I
Because
must also say, Dr. Prasad, sometimes you would not get a concordance and you would get panic and you would also start doubting the CTC, but don't give up because we also fail sometimes.
so it's like an learning curve, and as you rightly said, each patient is unique. I had a patient who was on T3N1 colorectal carcinoma, young guy, 46, 47 years, completed surgery, completed 4 cycles of chemo. We did a CTC, it was positive. So for whatever benefit, we completed up to 8 doses of chemo. That's the
Right.
thing. And after that, it was still positive.
So continue to monitor for another 6 months, and based on the immunity, T cells probably would do their job. So giving up a patient because their treatment is complete. Now I think there is a role of your immune system to evade all of them. I had a patient yesterday, after as a GI patient, 2 time points we found positive. He came from actually Africa. Patient from again South India. I don't want to reveal the name of a doctor. Absolutely, yesterday we had a zero CTC. This is Dr. Dattatraya's patient, by the way. I would be very glad to tell. And he said, I want patient to be monitored until we find a zero CTC. That's what I want to do. Right. So some patients are, they can do it. There's also cost burden, over diagnostication. But thank you very much for your insight. I would like to actually see the data, present it to ASCO, show it to the world because we can also teach them a lot of new information.
technically, as per the guidelines, we only 4 doses of Capox, but we went ahead up to 8, and we don't have data beyond 8. So I had to stop, but probably keep the patient on a monitoring. Probably that one CTC positivity should keep the patient on a regular follow. So that's something which I had also learned. Probably when we do a lot of CTC, ctDNA follow-ups, we will understand more about it and probably implement it in our future practices for the right test for the right patient. So
absolutely.
Yeah, thank you so much, sir. So next session would be from Dr. Arumugam, who is the professor of
one more
medical
question. I'm
oncology.
having one question, Prasad.
Yeah, Rajan.
Prasad,
Please
I
go
have
ahead,
one
Rajan.
question. In that situation, at what intervals should we repeat the CTC monitoring if it is positive at one time?
See, for hormone positive patient, the outcomes are better in hormone positive cases. So you might want to look at 5 or 6 months of a time. HER2 positive, probably 3 to 4 months of a time. TNBC, maybe every 2 months of a time. So I will share the slides where there is a complete, analysis of each disease stage and where you would like to have a possibility of a CTC. So can I share these slides with Dr. Raja, with Dr. Prasad, so that this can be given to every oncologist freely?
Okay, better.
And
You can
you
share.
might actually, tune your own understanding depending on every patient. And Arvindan has made a fantastic, I will not say a guideline, but our own internal experience-based thought processes, which might not be correct, but we would like to run it. So Muthu, I would request you to share these slides to Dr. Prasad and to all the doctors which are actually present here, including Dr. Raja, to you.
Yeah.
Is that fine,
Thank
Dr.
you.
Raja?
Yeah, I have one patient. In the first month, he showed one CTC positive, DNA negative, and second month, 3 CTC was positive.
So what was the stage
Urinary
and what type
bladder.
of a cancer? Urinary bladder.
Post-op.
Right. So I would say that go for the third time point, because after surgery, was there a surgery or
Yeah. It's
so after the
post-op.
surgery? So post-operative, these cells are likely to be higher, but they might go down based on actually the progress, the response. So I think CTC is also used, Dr. Prasad, as a treatment response monitoring test. Right? It is not a treatment decision biomarker, but it's a treatment response
monitoring.
monitor.
Okay.
Right. And that tighter you will have to do it. So in this RCC case, this is our also experience, Dr. Raja, that the patient might have a higher number of CTC for 6 to 9 months, and then it might actually go down.
Oh, okay.
Okay, right. So continue to monitor, because if you stop and if you find the CTCs are continued, that means there is a continual stable disease. Okay. So three CTCs or 2-3 CTCs, that means there is a still lurking minimal residual disease. But most of the good patients, I think they would have slowly down, number of a cell, follow up a CTC number.
Okay, thank you.
Thank you.
Thank you so much, sir, for that enlightening talk. So may I invite Dr. Arumugam to give us an insight of what advances do we have in locally advanced and early non-metastatic breast cancer disease. Over to you, Dr. Arumugam, sir.
Yeah, thank you. Thank you, Dr. Prasad. And I thank the organizing team for wonderful opportunity to present. So my topic was a little bit changed to enlightening on the circulating tumor cells in cancer. So the other part of the locally advanced breast cancer will going to talk by Dr. Prasanna. So my topic is CTC. Yeah, next slide. Yes. So what is circulating tumor cells? The circulating tumor cells are cancer cells that detach from the primary or metastatic tumor and enter into the bloodstream or lymphatic stream. So these cells represents the physical manifestation of the metastatic cascade, a biological process responsible for over 90% of the cancer-related death. CTC serves as a critical component of liquid biopsy approach and offering a minimally invasive window into tumor biology and providing real-time information about disease, status, treatment response, and molecular evaluation of cancer. Next slide. So this is the metastatic cascade, a multi-step process. So detachment and intravasation, survival in the circulation, extravasation and colonization. This is the metastatic cascade. So the cancer cells undergo EMT, that is epithelial mesenchymal transition, and losing the E cadherin and gaining migratory properties to invade blood vessels. And there's the CTCs face hostile conditions with less than 0.01% survival rate due to shear stress and the immune attack. And the surviving CTCs undergo again the MET, that is mesenchymal epithelial transition, and adhere to the distant organ and proliferate to form metastasis. So this cascade represents the journey of tumor cells from primary site to distant metastasis colonization, with CTCs serving as the critical intermediary population. So this is what is the meaning of epithelial to mesenchymal transition. Next slide. So this is a fundamental biological process. Next slide. It's a fundamental biological process enabling cancer cell dissemination. So during EMT, epithelial cells lose cell-to-cell adhesion molecules like E cadherin and acquire mesenchymal characteristics, including enhanced motility and invasiveness. Then this phenotypic plasticity allows tumor cells to detach from the primary mass and invade the surrounding tissue. At the distant sites, the reverse process, that is MET, mesenchymal to epithelial transition, occurs and facilitates the colonization and metastatic outgrowth, and creating a dynamic biological cycle central to cancer progression. So this CTC heterogeneity is a complex population. Next slide. So the epithelial CTCs, mesenchymal CTCs, hybrid CTCs, and CTC clusters. So this heterogeneity presents both a detection challenge and an opportunity for understanding the metastatic biology at unprecedented resolution. So three key applications, the clinical utility. Next slide. One, it can be used as a prognostic biomarker, predictive biomarker, and used as for early detection and the MRD. So CTCs offer advantage over traditional tissue biopsies by providing non-invasive, real-time, comprehensive tumor information across all metastatic sites. Next slide. So the FDA approved CTC enumeration cell search system, so validated prognostic tool. The cell search system represents the gold standard for CTC detection utilizing immunogenetic enrichment targeting the epithelial cell adhesion molecule, which is also called CD326 positive cells, followed by immunofluorescence identification. So FDA clearance was granted for monitoring metastatic breast, colorectal, and prostate cancer based on the robust clinical trial evidence demonstrating correlation between the CTC and the patient outcome. So next slide. So prognostic evidence of survival correlation was showed in the metastatic breast, prostate, and colorectal. Next slide. So the real-time treatment monitoring, it can be used as a dynamic response assessment. Serial CTC measurement during therapy provide a real-time feedback on treatment efficacy, often preceding radiographic changes by the weeks to months. So decreasing CTC counts indicate favorable response. Persistent or rising counts suggest resistance and earlier intervention point than imaging. So clinical implication, this dynamic monitoring capability enables adaptive treatment strategies, allowing clinicians to modify therapeutic approach based on the molecular evidence rather than waiting for the radiographic progression. So studies show CTC response at first follow-up correlates strongly with the ultimate clinical decision outcome. So the precision medicine is used to isolate CTC, extract nucleic acid, molecular profiling, identify targets, and guide treatment. So this approach transforms the CTCs from simple enumeration tool into comprehensive molecular diagnostic platform for personalized cancer management. Some clinical examples we can see. Next slide. So the HER2 discordance in the breast cancer, the tumor evaluation and the treatment implications. Receptor status discordance between primary tumor and metastatic disease occurs in about 10 to 40% of the breast cancer cases. And HER2 status in particular shows a significant heterogeneity over time and across the metastatic site. CTC-based HER2 assessment can reveal HER2 positive population in patients with HER2 negative primary tumor, potentially identifying candidates for HER2 targeted therapies like trastuzumab or pertuzumab who would otherwise be excluded. So several clinical trials have demonstrated that CTC HER2 status may better predict response to HER2 targeted therapy than archival tissue testing. So next example is in the EGFR mutation in NSCLC. Next slide. So CTC guided therapy. So initial diagnosis EGFR mutant NSCLC detected treatment with the first generation TKI either gefitinib or erlotinib. And the treatment response CTC count decreases, but EGFR mutation remains detectable in the circulating cells. So we can check for the acquired resistance. So CTC analysis reveals emergence of T3 T790M resistant mutation before radiographic progression. So then you can switch the treatment to third generation TKI with osimertinib. So this real world scenario demonstrated how CTC molecular monitoring enables proactive treatment adjustment, potentially improving outcome by adding resistance mechanisms before clinical progression. So next we can use for the drug resistance monitoring. Next slide. So the serial CTC analysis enables the longitudinal tracking of tumor evaluation under therapeutic pressure. As treatment eliminates sensitive clones, resistant subpopulation emerge and can be detected in the CTCs before manifesting as clinical progressions. So one may be a genomic alterations. So detect resistant mutation emerging under selection pressure and gene amplification and the protein expression. So this dynamic resistance profiling represents a paradigm shift from static tissue biopsy to continuous molecular surveillance. Early detection and high-risk screening, CTCs before clinical metastasis. So emerging evidence demonstrates CTC detection in patients with early-stage non-metastatic cancer and even in high-risk individuals without confirmatory malignancy. For example, in a stage 1-2 breast cancer, 1 or 2 breast cancer, CTC detected in 20 to 30% of the patients. Localized prostate cancer, CTC is found in patients with elevated PSA. Then precancerous lesions, rare detection suggesting early dissemination. So the risk stratification based on the CTC presence in early stage disease correlates with higher risk of disease recurrence, shorter disease-free survival, more aggressive tumor biology, then potential need for intensive adjuvant therapy. Then another is the MRD detection. Next slide. So MRD detection, the clinical significance, the MRD detection via the CTC represents the most sensitive method for identifying patients harboring micrometastatic disease who remains at high risk for relapse, potentially guiding adjuvant treatment intensification or enrollment in the clinical trial. So the technical challenges in the CTC detection. Next slide. One is extreme rarity. The CTC exists at a concentration of approximately 1 to 10 cells per ml of blood. So requiring highly sensitive detection technologies with minimal false positive rates. And biological heterogeneity, no universal CTC marker exists. The EMT creates epithelial marker negative populations that evades the EPCAM based detection and potentially missing the most aggressive metastatic component cells. The technical standardization, multiple isolation platforms yield different results. And the viability and function, most methods cannot distinguish viable from apoptotic CTCs and functional characterization. So addressing these challenges represents the current frontier of CTC research and technology development. So other technologies in the diverse landscape, so immunogenetic selection, microfluidic devices, size-based filtration, density separation, flow cytometry, and molecular methods. And the future directions, single cell sequencing. Next slide. The future directions are single cell sequencing, CTC derived xenograft and organoids, and functional assays. So this field is transitioning from simple CTC counting to comprehensive functional and molecular characterization, promising truly dynamic and personalized cancer management. So the integration into the clinical practice in the current status, established applications, FDA approved prognostic use in the metastatic breast, prostate, and colorectal by the cell search method, and NCCN guidelines acknowledges CTC potential but don't mandate routine use, and research applications in the clinical trials for therapy selection and MRD monitoring. There is some barriers for adaptation or lack of standardized protocols across platform, and cost and reimbursement challenges, and need for the prospective interventional trial demonstrating clinical utility, and limited availability outside the specialized centers. So these are the transforming cancer management through the liquid biopsy, non-invasive real-time tumor assessment, and biological insights, understanding metastatic mechanism, early detection, and risk stratification and MRD assessment. So circulating tumor cells represents a paradigm shift in oncology from static tissue analysis to dynamic, comprehensive tumor monitoring. As technologies mature and clinical evidence accumulates, CTC promises to deliver on the vision of truly personalized adaptive cancer therapy guided by molecular evidence rather than the anatomical imaging alone. So CTC clusters enhanced the metastatic potential. Next slide. So these are the while rare circulating tumor clusters aggregates to 2 to 50 plus cells are highly significant drivers in the metastatic disease. So these clusters exhibits 50 to 100 times greater metastatic potential than the single CTCs. Next slide. So the CTC-derived organoids, the ex vivo drug testing, the circulating tumor cells are not just diagnostic markers. They can be cultured into 3D organoids, so offering a powerful platform for personalized cancer treatment. So the challenges, key advantages are non-invasive, real-time tumor biology from blood draw, and the personalized direct testing on patients' own tumor cells, and allows repeated testing throughout the treatment, and provide predictive models for new therapies. So hurdles are rarity, low success rates due to the extreme scarcity of CTCs, and requires a specialized technical expertise and advanced laboratory infrastructure, and need for universal protocol for the consistent and reproducible results. So the future of liquid biopsy, so non-invasive, the CTC represents a paradigm shift from the invasive tissue biopsies to real-time, non-invasive tumor assessment and prognostication. And continuous technological innovation is refining the sensitivity and specificity of CTC detection, overcoming previous limitations and accelerating clinical integration. And the future lies in the integrating CTCs with other liquid biopsy analysis, such as ctDNA and exosomes, for multidimensional tumor profiling, offering unparalleled diagnostic depth. And CTCs are moving from a research tool to routine clinical decision-making instrument, enabling dynamic, personalized cancer management and treatment strategies. Thank you. So over to you, Dr. Prasad. So I want to ask two question to Prasad. So are you doing the CTCs routinely? Because you discussed with the previous speaker, that's why I'm asking.
Patients, we would want some answer. We need to either stop the treatment or at least convince the patient that they need to be on treatment, because there are some radiological factors or the clinical parameters which would make us kind of be more specifically evaluating certain patients. And of course, it's only for those who can afford. So not a routine practice, but there are certain patients who we think CTCs will definitely be monitoring. But of course, it's indicated, just like how we decide about doing a PET CT
Yeah.
scan and a normal routine CT scan.
So how
Yeah.
you select the patient, sir? How, to in which to whom you do CTC? Any criteria you have?
In the sense, say for example, if stage 4 patient who wants to stop the treatment, who would keep, I mean, after a radiological complete response, I mean, this is a real life case. That breast cancer patient had a radiological CR for more than about 2 years now. Same as the endometrial carcinoma patient. The breast cancer patients, I said, you have to continue on a HER2 positive disease. So trastuzumab at least needs to go on. So that was being continued. But this patient had a CTC ctDNA negative. There's also another endometrial carcinoma patient who wants to stop the treatment, but in them it was CTC positive, ctDNA was negative. So in these two are the clinical scenarios in a metastatic setting where I have a radiological evidence of a complete response. One breast cancer patient has a complete CTC ctDNA negative, but can I stop the treatment? Is $1 million question, which I am not able to answer myself. But when we say to stop the treatment and when if the disease recurs, it's quite a difficult thing. So that is the reason why I kind of wanted to have at least about a CTC ctDNA for these two patients at least, for at least 4 or 5 testing, each at around 3 or 4 month intervals, because both are HER2 positive, but breast and endometrial carcinomas. We never know how these patients would relapse. And it is quite rare to have a stage 4 patient with multiple lung and bone metastasis, liver metastasis having a complete response. So there's no defined criteria for which selective patient should I do a CTC or a ctDNA. But the question is, when the patient wants to stop the treatment in stage 4, we need to have some kind of a backup. At least based on
Good.
this, I have stopped the treatment based on the patient's request. Of course, it might not be legally valid. I'm not sure whether it is legally and acceptable or scientifically approved. But at least I have some backup to counter my own questioning whether it is justified to stop the treatment or not. So we are all still learning about CTC and ctDNA. I think we need to understand by doing a lot of tests to know which would be the ideal patient and how we need to interpret the results to our routine daily clinical practice.
Sir, one more question. On follow-up also, you follow up with PET CT along with ctDNA or CTC, or you are doing only
My personal
image follow-ups?
understanding of this is I try to do the PET scan and CTC ctDNA at the same time. Say for example, in 1 month, say for example, December first week, I would say if I had done this thing, the next April or June, I will tell the patient to do it in the same month at least. At least I have one radiological evidence with a molecular evidence to see whether there is a correlation or not. Anything
Okay.
else, please? Yeah.
Yeah.
Sir, any great? Yes, sir. You ask, sir.
Yeah. I'm having a patient with the HER2 positive metastatic breast cancer. Patient is receiving the same for the 2 years. Patient is both pertuzumab and trastuzumab. But I don't know when to stop. So, do you recommend to do CTC? Multiple times we did a PET scan and everything is normal, clinically normal, PET scan normal. So, can we go with as per the this presentation? So, I today only I read this presentation. So, the CTC and ctDNA is enough to plan a stoppage of treatment.
Jayant, this question is for you.
Right. So as Dr. Prasad mentioned, I think there is more evidence coming, doctor. But I think if you want to be a confirmative biomarker like a DNA, post-surgery. I mean, what we have been discussing about, say, late stage or say RCC at late stage, etc. But my counter reaction, Dr. Prasad and Dr. Arungan, is that when the patient comes even at an early stage, and patient has an, say, surgery, for example, and post-surgery, you have an ACT or you have an adjunct therapy or chemotherapy radiation. In those cases, I would request you to actually do a baseline CTC number before the surgery. So now, before the surgery, if patient didn't had a CTC, I can assure you, with our sensitivity, the disease is localized. It is not in the systemic circulation. Now, as you also presented, when you do a surgery, the patient who didn't had a CTC probably will have CTC now in the circulation. So surgery often is a failure. It actually extends the possibility of a disease from one point to next distant organ. That's a sad story of a surgery underwent patient. Now, post-surgery, if you monitor this patient and you didn't had a CTC, that means your resection with a curative intent was absolutely great. So you don't have a localized tumor, you don't have a disease in systemically, as well as you should not worry for this patient to monitor later on. But before surgery, after NACT, after your adjunct therapy, if patient persists to have DNA as well as CTC, then the patient is not actually has not responded well, in spite of a PET scan negative. So that's where actually it's a critical, your intuitive decision. Based on actually using several times CTCs, you will come to know slowly that which of a patient are likely to come back with a recurrence and which of a patient would not likely to come back. I would not suggest to do CTC in metastatic setting because it's a very obvious that the patient will have CTC. I hope, Dr. Prasad, there is.
I have as of now sent two in the adjuvant setting, two in the two colorectal adjuvant settings, two metastatic, one breast and one endometrial metastatic.
So now what you are doing is actually you are finding your own insights, right? You are finding own insights. So you are more smarter than other oncologists, I'll say, because we are adapting the test wherever there is a possibility.
Or he may calculate the reduction of CTCs.
Yes. So as the CTC number goes down, right, from the baseline. So if baseline had 4 CTCs, after surgery, this number actually went down to 1 CTC or 0. That means I think the progression of disease or the response to your treatment is getting better. And only 10% of patients would actually be favorable to have no CTC. Trust me, I have 11,000 patient data, so I can say that very confidently. No other company has 11,000 patient data. They would have 500 patient data, 200 patient data, 75 patient in pancreatic cancer patient. By spending 80 million euros, they have a data of at least only 500 pancreatic cancer patient. Can I share my very quick 30 seconds point? I got a patient's blood sample with a pancreatic from another Apollo hospital in Chennai. The treatment was complete, nothing was on the PET scan. The family insisted to do CTC. Unfortunately, we found CTC. 79-year-old, very, very important patient, today is alive with 13 time point CTC monitoring. 86 age, the patient with pancreatic cancer with CTC monitoring is absolutely is completely remission. So now there is no guideline. So I mean, you also said there is nothing in a guideline, right? But DNA is also not in majority of a guidelines, but the evidence-based data in clinical trial shows that there is a good correlation. Thank you.
Sorry, if there is any image is normal, and if there is a CTC positive previously with the treatment it is decreased. Have you come across a situation like this, sir?
Yeah, I showed a quadrant, right? So what happened? I would say that in 99% times your your PET would be negative and CTC would be positive. If a patient had 752 millimeter of a disease, which cannot be detected by the PET scan, and that's the biggest dogma in oncology, that we use CT PET scan before the diagnosis, for the intervention, and also for the surveillance.
Sir, in this situation, what will you do, sir? If the recurrence is imminent, or it is going to come in such time, or you will start treatment, or what?
No,
We don't know when a CTC will be radiologically presenting as a metastatic disease. We never know.
Sir, pardon, sir. No,
When
image wise, if it is normal and you detected a CTC or ctDNA, what is the next step, and how will you proceed?
in an adjuvant, we not eternally giving the patient chemotherapy to CTC. So I had to stop at a specified number of cycles, what the guidelines say, or maybe put them on a metronomic therapy or whatever for an additional a couple of months, but not eternally, because we do have the toxicity also, which needs to be monitored in an adjuvant curative setting. When somebody sees me giving capecitabine or capox for 2 years, they laugh at me. So it has to be a calculated decision wherein the patient, family members, as the doctor, need to have a proper understanding before extending the treatment in the adjuvant setting. They cannot just continue the treatment based on the CTC, ctDNA. But whereas in the metastatic setting, the guideline says to continue the treatment, a patient with only a radiological CR and blood markers positive, do we have an indication to stop the treatment? We are learning. Probably when we are talking about CTC, ctDNA in 2035, that time it might come in the guidelines. Say, for example, if PET-CR and CTC, ctDNA negative, consider further observation. Maybe, but we need to, again, as Dr. Jayant had said, he has 11,000 patients. Probably by 2035, we might have 11 lakh patient data. So that point of time, we have a robust data to say that, yes, my CTC, ctDNA, if it is negative, radiological CR, I can stop the treatment even in a metastatic patient. As of now, it's a personal decision, probably a shared discussion and a decision between the family and the treating physician, because we are in an era of medical legal litigation and we don't want to get into unnecessary problems. So this is beyond what we do have these standards at this point of time. A good, well-informed patient who is capable enough to understand the doctor's words in the right way to make sure that it's going to help them. Probably we need to choose that patient to put on a CTC and ctDNA. That's my personal way of choosing which patient I would prescribe a CTC, ctDNA. No, definitely not for all patients, of course.
Sir, actually, my
So Sir, sorry to disturb you. We are already 10 minutes late, so kindly conclude.
Yeah. This is one question. Sir, when the patient is on follow-up after a complete remission, radiological or ctDNA, so you have a situation like the image is normal, but there is appearance of CTC or ctDNA. So what will you lose?
My personal practice is not to treat, but probably if I have previously done the CTC, ctDNA once in 6 months, I would probably repeat the test in 3 months' time, at least to see if there's any foci of metastatic disease which is coming up radiologically as well as in the blood. Say, for example, after 3 months, if my PET scan is normal, but my CTC, ctDNA score is increasing. So this is a patient who I would still have to have monitoring in the next 3 months, not after 6 months. Because this patient is definitely going to fail. But am I going to start a treatment for a patient with only an increasing CTC value? I will not, as on this date. I will not start on a treatment based on only the increasing CTC, ctDNA values. Correct me if I'm...
Right. See, what happened in colorectal cancer, there is always debate, 3 months or 6 months of a treatment, right? So there is a evidence that has been there that 3 months versus 6 months in colorectal cancer patient, they have identified patient were treated only for 3 months had actually the follow-up CTC as well as in 6 months, but later on there was a mutagenic registrant that came in from the cells, and the patient had actually worse outcome than the 6 months of a treated patient. So underlying chemotherapy treatment in colorectal at least can be taken decision. HER2 positive, HER2 negative 2 times CTC, there you might actually take a call to have a short gap of Herceptin if it is possible. Nothing is in the guideline, but it is your own decisions.
I mean, guidelines will come after 5 years, after we all started practicing.
Right, absolutely.
So maybe we can still continue our discussion later. I'd like to go ahead with the question. Probably we are getting late. So next would be a kind invite to Dr. Prasanna to have a discussion on advanced breast cancer management in hormone receptor positive disease. Over to you, Prasanna.
Yeah. Thanks, Prasad. I'd like to thank Dr. Prasad for giving the opportunity and also the organizers for this wonderful webinar. It was an enlightening lecture by Dr. Jayant on circulating tumor cells and ctDNA. So let us shift gears for listening to advances in management of hormone positive advanced breast cancer. Next slide, please. So this is the outline of my talk. So first, let's discuss the magnitude of the problem. Then we go about listening something about endocrine resistance, and we'll discuss standard of care in advanced breast cancer, especially hormone receptor subtypes, and also novel agents. And finally, we'll end up with the guidelines and the treatment recommendations. Next slide. So we know that breast cancer is the most common malignancy among females and has the highest mortality rate, especially in the world and also in India. Next slide. So the magnitude of hormone positive breast cancer. So this is notorious for both early and late recurrences, because 50% of recurrences can occur even within 5 years of diagnosis, especially in a luminal B subtype, whereas in luminal A, the risk of recurrence remains beyond 20 years. And again, the studies have said that the risk of recurrence remains consistent irrespective of the nodal status. So the majority of all invasive disease events would be a distant recurrence in the form of a hormone positive advanced breast cancer. Next slide. So whenever we diagnose stage 2 ER positive breast cancer, so there is always a chance of 30% patient will represent or experience recurrence within the 20 years after the standard of care treatment or the comprehensive treatment. And whenever we have a patient with stage 3 early ER positive breast cancer, at least 50% of these patients can recur in the next 2 decades, even with the current standard of care. Next slide. So with this, background, let us discuss some clinical scenarios on how hormone positive metastatic breast cancer has been divided into clinical scenarios. One would be a de novo metastatic breast cancer. At least 30% of the breast cancer are being diagnosed in very later stages, especially in advanced stage. So we are now looking at a lot of de novo metastatic breast cancer in our clinical practice. And also some of the patients can recur after 12 months of end of the adjuvant endocrine therapy. So these patients are endocrine sensitive patients or late recurrence patients. And the next clinical scenario would be early recurrence, where the patients recur less than 12 months after the end of your adjuvant endocrine therapy, where they show signs of endocrine resistance. And some patients, probably 5 to 10% of our patients, can land up with the imminent organ failure or visceral crisis. Next slide. So this is the timeline of how the targeted therapies for hormone positive breast cancer has developed. So in early 1990s, we just had the option of just GnRH analogs. Then came the option of aromatase inhibitor, and then the SERMs have come into practice, especially the raloxifene, and the SERDs have come into practice in early 2000s, like fulvestrant. And we had the incoming of everolimus, that is mTOR inhibitors, and in few decades, just 1 decade ago, we have the influx of CDK4/6 inhibitors and has now become a standard of care in our day-to-day practice. And in 2019 came PIK3CA, the first generation alpelisib, and now in 2023, the second generation SERD, that is elacestrant, has come into practice. Next slide. So this is the main HR signaling pathway and the mechanism, basic mechanism of all the approved drugs which are targeting the ER. So since this is a medical oncology group, I will just skip this and go to the next slide. Next slide, please. So next slide. Okay, so let us discuss something about the endocrine resistance. So whenever we have a treatment pressure or some therapies have been applied on the tumor profiling, so these tumors, they retain some form of endocrine retaining activity. So some form of AA resistance would be present, but still these tumors may be dependent on ER dependence, and so that we have to choose the next anti-endocrine therapy regimens. And some other tumors, they become totally endocrine resistant. Next slide, please. So here we have a typical patient who are resistant to AI, but they can be ESR1 mutant positive. So at least 30 to 40% of the post-AI patients who have developed a secondary hormone resistance can be ESR1 mutation positive. Next slide, please. So this is the basic standard of care as what we do in our routine clinical practice. Whenever we diagnose metastatic breast cancer, we tend to rebiopsy whenever the tissue is available. And you know that the IHC panel, there can be discordance over the hormone receptor, especially ER and PR, 20 to 30% of patients. The loss is more common than the gain. And also in HER2 discordance, also more common, like 8 to 10% of patients. The HER2 loss is again as well as seen, and also gain is also seen, especially in our clinical practice. Next slide. So how do we evaluate the targetable biomarkers when we come to a metastatic breast cancer setting? So we have two options. Whenever a tissue is available, we go for tissue-based NGS. Like if in hormone receptor positive patients, we go for PIK3CA, AKT1, ESR1, and also PTEN. It's a comprehensive NGS panel available. And when a tissue is not available, we switch over to liquid biopsy. We go for somatic ESR1 mutation and other mutations as well. Next slide. So these are the ESMO scale of actionability molecular targets as SCAT scale. And we have seen that PIK3CA and ESR1 mutations are all category 1A recommendation in terms of the genomic alteration testing. So ESMO has endorsed the use of all these even in NGS and also as part of a separate platform status. Next slide. So whenever we do a sampling study, especially from a tissue or liquid biopsy, so probably we look into all these four biomarkers, especially on molecular profiling. As I said, AKT, PIK3CA, PTEN, and ESR1. Next slide. So how do you personalize our targeted therapies with molecular markers? So what mutation to test and when to test, that is especially the time is critical, especially when you have a sequence of endocrine therapy being applied for advanced breast cancer. And you have to also consider other confounding factors like clinical factors, comorbidities, and combinational resistance. So all these things has to be taken into account to find a molecular marker which can be druggable to give a personalized therapy. Next slide. So I think the first line endocrine therapy, CDK4/6 inhibitors have become the standard of care in advanced breast cancer. So we have a OS benefit, OS of at least more than 60 months whenever we put a patient on CDK4/6 inhibitors in advanced breast cancer setting, especially in the form of endocrine sensitive relapse. So we have several trials based on abemaciclib, palbociclib, and ribociclib. So with a good PFS benefit and also OS translation benefit. Next slide. So let us discuss something about ESR1 mutation in hormone positive breast cancer. In endocrine naive, the incidence of ESR1 mutation is just 1%. So we need not worry about that. Whenever a patient has some prior adjuvant AI, the incidence is just less than 5%. So again, the tumor microenvironment does not come into picture here. But whenever we expose the patient after AI, with or without CDK4/6 inhibitor in advanced setting, the incidence of secondary ESR1 mutation is going to be as high as 40 to 50%. Next slide, please. So this is again the mechanism of action of how the ESR1 mutation alter the ligand binding domain of estrogen receptor, which results in a ligand independent activation of the cancer growth, metastasis, and resistance. And so the presence of ESR1 mutation decreases the affinity of ER for estrogen and also SERMs and SERDs. So your fulvestrant may not work to the brightest level, and the AI and tamoxifen has become a dead horse. Next slide, please. So this is the Emerald trial. This is the classical trial which proved that elacestrant has now become the standard of care, especially in patients with ESR1 mutation. Next slide. So as a patient with survival benefit, yes, PFS benefit of 40.8 months in a patient with ESR1 mutation versus fulvestrant of 20.8 months. So nearly the doubled PFS rate. Next slide. And also when the patient has been exposed to at least 12 months of prior CDK4/6 inhibitor, the median PFS is very high, especially 8.6 months versus just 1.9 months versus the standard of care. And the longer the time period of CDK4 exposure, the better the PFS benefit with elacestrant. Next slide. So next slide, please. So these are other oral ACRDs has now become come into practice, especially the camizestrant is making a big wave, especially in ESMO 2025 and ASCO 2025. And also the Electra study has been making to have a combo of elacestrant with other CDK4/6 inhibitors. So probably in the next few years, these will become a standard of care, or new studies will come. Next slide. So again, the testing for ESR1 mutation is pivotal because it can also be tested by liquid biopsy, not only by tissue-based NGS, it can be tested by liquid biopsy. And the phase 3, the PADA-1 has study is the real-time ctDNA serial monitoring to detect ESR1 mutation. So this is again in correlation with Dr. Jayan's talk about the ctDNA testing or serial monitoring of ctDNA. Next slide. So this is the latest Serena-6, and this has now become a game changer, especially when presented in ASCO 2025. The patient on surveillance with ESR1 mutation, the patient with metastatic breast cancer, hormone positive, on AI with CDK4 inhibitor, the patient has a stable disease, but ESR1 mutation has been tested every 3 months by ctDNA, and whenever they find the ESR1 mutation, they switch over the therapy to camizestrant, and with continuing CDK4/6 inhibitors. So probably we are looking at something game-changing, especially according to Serena-6. Next slide. So this is the camizestrant with the CDK4 inhibitor. The median PFS is excellent, like 16 months versus 9 months when you follow a standard protocol. But when a patient is ESR1 mutation positive, switch over to camizestrant, you elevate your PFS benefit of 16. So probably a 7 months PFS benefit when you switch over to camizestrant. Next slide. So next slide, please. So yeah, so this is the traditional approach we follow as of today. So we monitor the response to treatment by RECIST, by PET-CT scan, and only when we have a radiological progression, we switch over to second-line therapy. But what the newer paradigm would be, you will be a serial monitoring of ESR1 mutation by ctDNA, and you switch over to a better ACRD whenever you have a ESR1 mutation positive. So probably this may become a new paradigm or standard of care, especially in the near future. Next slide. So these are other ACRDs or oral seren. So this is the new kid on the block, palazestrant. Palazestrant is complete oral ER antagonist and also a ACRD. So this is a combination of seren and ACRD. This is just into the phase 2 trial. The clinical benefit rate is 40%. And again, this has a very nice effect in ESR1 mutant patients. Next slide. So this is the OBRA study based on what the palazestrant have been studied. So probably the results of OBRA study will throw some light on the use of palazestrant in ESR1 mutation patients as well. Next slide. So this is something about the PROTAC. So PROTAC is a proteolysis targeting chimera molecule. This is a new kid on the block, Webdescript. So Webdescript is being presented in ASCO 2025. Next slide. This is the VERITAC trial where the Webdescript is 200 milligram once daily was presented. Especially, again, this is more pertinent when it comes to pre-exposed or heavily treated patients exposed to your CDK4/6 inhibitors plus endocrine therapy. So now we know that the standard of care would be a second line fulvestrant, but especially these patients are being stratified into ESR1 mutant or not, on patients with visceral disease or not. Next slide. So VERITAC will be soon publishing the results, and the early results shows that the PFS benefit of median PFS of 5 months versus the fulvestrant of just 2 months. This again shows a promise in ESR1 mutant patients as well. So probably the long follow-up would be needed. So the next overview would be the pathway alterations in PIK3CA or AKT or mTOR pathway. As we all know, we use a lot of everolimus, especially as a part of mTOR inhibitors in third-line hormone-positive breast cancers nowadays. But still, we have a PIK3CA mutation being more prevalent, especially up to 30 to 40% of the advanced breast cancer and hormone receptor positive patients develop a secondary endocrine resistance with PIK3CA mutation. Next slide. And this is again a new kid. We know that first line, first generation alpelisib has got a lot of toxicities, especially the hyperglycemia, mucositis, and stomatitis. But now the inavolisib is a new kid on the block, the second generation PIK3CA inhibitor, selective inhibitor. So it promotes the degradation of mutated 110 alpha mutant degrader. So it has a positive results in the INNOVA 120 trial, again presented in ASCO 2025. Next slide. So this is the INNOVA 120 trial where the PIK3CA mutated hormone positive advanced breast cancer patient had no prior therapy ABC, and the patients probably progression within 12 months of endocrine therapy completion. Next slide, please. So this is again the positive trial, the median PFS of 17.2 months versus 7.3 months of placebo. So the ASCO 2025, the inavolisib is making a new wave, especially in PIK3CA positive patients. Next slide. Next slide, please. Okay, so this is the capivasertib. Capivasertib is again the AKT inhibitor, where the heavily pretreated patients for endocrine therapy and also even with chemotherapy, prior chemotherapy. So patients again compared with the standard of care fulvestrant. Next slide. So again, it has the PFS benefit when compared to the fulvestrant. Next slide, please. So especially when your AKT pathway inhibitor, AKT pathway is being altered, so capivasertib is an answer for it. So we have a class toxicity, especially when it comes to AKT pathway and also the PIK3CA inhibitors. You have the hyperglycemia, and alpelisib has got the highest rate of grade 3 hyperglycemia.
Sorry to interrupt you, sir. Please conclude in 2 minutes.
Just 5 minutes. Yeah. So hyperglycemia, but the inavolisib is a new kid on the block, is now has just a 5% of grade 3 hyperglycemia, and also the capivasertib, the AKT inhibitor, has just a lesser incidence of hyperglycemia. Next slide. Next slide, please. So also this is a skin toxicity. I will not dwell upon it much. So skin rash is also more common as a class toxicity of PIK3CA and AKT inhibitors. Next slide. And also the these are other presentations of clinical manifestation of skin rashes. Next slide. And this is again the next class toxicity of stomatitis or mucositis with capivasertib inavolisib. Next slide. So we use the magic mouthwash or dexamethasone. So this is the current guidelines we follow for metastatic breast cancer, the ESMO clinical practice guidelines, and big practice guidelines. Next slide. So next slide, please. So this is again based on the ABC7 recommendation. Next slide. So this will be the final flow chart of how we go about. So we classically test for the PIK3 mutation status and ESR1 mutation status, especially when the patient has been exposed to on AI or even CDK4 inhibitor, and also AKT1 mutation status. Next slide, please. So this is the overview of how we manage hormone positive advanced breast cancer. So the first line as standard of care, we know that CDK4/6 inhibitors with endocrine therapy. When the patient progress, again we divide it into PIK3CA mutant or AKT1 mutant or ESR1 mutant. So still we do not have the luxury of using elacestrant, so we go with just fulvestrant. But when we have a PIK3CA mutant, we try for some alpelisib the patient is tolerating, but still alpelisib is not tolerant for most of the patients. So we wait for capivasertib to be launched in India. So still we have only the standard of care. The second line would be the fulvestrant or probably exemestane with everolimus. Next slide, please. So the final thoughts due to the new strategies are being explored for the different patient population for optimizing the treatment, especially in hormone positive backbone, and wait and watch, especially the ctDNA for endocrine sensitive patients. For now becoming the monitoring is becoming now the standard of care, especially when the patients are on AI with CDK4 inhibitors. The patient has a stable disease on PET-CT, and now for endocrine refractory patients, we have novel oral SCRD alternatives, and also the ADCs also in the new treatment landscape, probably for HER2 low or ultra low populations. Thank you so much.
Thank you, Prasanna, for that elaborate talk. You are the ABC specialist right from our PG days. We started from the first guidelines, and thank you so much for that wonderful presentation. So I'd like to call Dr. Pandurai. Sir, are you there?
Yes, sir. I am here only.
Request your next presentation on advanced ovarian carcinoma, newly diagnosed advanced ovarian carcinoma. Over to you, sir.
Yeah, thank you, sir. Thank you for your kind introduction. So, can I share my screen? Yeah, thank you.
Sure, sir.
So my talk is going to be on the following topics, like the role of DNA damage and role of PARP and BRCA, HRD testing and guidelines recommendations, clinical evidence, recent evidence, and conclusion. So regarding the DNA damage, so DNA, we have a double standard and single standard DNA repair mechanism. So PARP is a base excision repair, which is a single strand break repair mechanism. When a homologous repair mechanism, which is BRCA and HRD genes, associated genes, which are deficient, only the thing which is going to repair the DNA is the base excision repair and NHEJ. So when we block the PARP enzymes, so there will be a base excision repair problem. So a single strand breakage with in a duration of time would lead into double strand break. So which is again should be to be repaired by NHEJ or homologous repair mechanism. When homologous repair mechanism is at fault, because of the BRCA G1 or 2 or other HRD genes deficiency, it will lead to accumulation of further it will lead to genomic instability. So this picture illustrates how the homologous repair pathway and the NHEJ pathway works. So HR is a high fidelity accurate pathway that restores the original DNA sequence by matched DNA strand template for the repair process. But NHG is an error-prone repair pathway that repairs the loose ends of the broken DNA double helix by sealing them together with no mechanism to preserve the original DNA sequence at the site of damage. So it may prone for wrong insertions, and which may lead to inefficient mRNA and non-functioning proteins. So this shows the inheritance of the BRCA. BRCA has two genes, two pair of alleles. So when one is lost, there comes a double hit theory. So the somatic and genetic and genetic inheritance. When genetic already the genetic lost BRCA, so the all cells will have no BRCA activity. So BRCA1 gene is located in chromosome 17 and BRCA2 is located in chromosome 13. So the risk of occurring cumulative risk of BRCA1 gene related breast cancer is 50 to 65%. And BRCA2 is 40 to 55%. For ovarian cancer, the risk is 40 to 65% for BRCA1 and 15 to 25% for BRCA2. So loss of BRCA1, BRCA2 creates a genomic instability. So increased gain of function of oncogenes or loss of function events leads to a cancer. So select this shows the double stranded DNA breaks, which can lead to chromosomal instability. So already explained that there is a germline versus somatic mutation. So when there is a double hit, the somatic mutation, so the organ which has lost the chromosomal gene activity will have that mutation, that is the somatic mutation. When there is a germline that is acquired BRCA, that is inherited BRCA, so the all cells won't have any BRCA activity. So for somatic testing, we have to take the tissue, and the germline testing, we can do it in blood or saliva. So HRD testing can be assessed by two different biomarkers. In ovarian cancers, these include individual mutations in BRCA1, BRCA2, and the genomic instability score, assessment of the genomic instability score. So HRD testing includes loss of heterozygosity, telomeric allelic imbalance, and large-scale transitions. So by which using these scores, we are going to calculate a genomic instability score. If BRCA1, BRCA2 negative and the genomics instability score is more than or equal to 42, they are uh, classified as HRD positive. In case BRCA1, BRCA2 positive and the score is less than 42, also classified as HRD positive. So when both are negative and they are classified as HRD negative. So this is the NCCN criteria for testing ovarian cancer for BRCA or HRD. So I will limit myself to ovarian. So other colleagues will tell the breast and other organs. So for personal history of epithelial cancer, all patients should be tested for BRCA. If unaffected person with a family history of ovarian cancer, they have to calculate a BRCA Pro score. If it is more than 5% or can risk of BRCA Pro, it's more than 5%, they have to undergo the BRCA and HRD testing. So here comes the synthetic lethality. When we block a PARP single strand break repair mechanism by PARP inhibition, which leads to accumulation of double strand breakage. When already a BRCA mutated patients, both alleles, which again lead to accumulation of more error-prone genes, then which can lead to cell death. That is called synthetic lethality. So these are the guidelines for advanced epithelial ovarian cancers. So after the 3 and 4 and first line platinum based doublets. So when they BRCA positive and they are in complete remission or in partial remission, so olaparib can be started, which is a category 1 indications. Even when they are initial treatment contain Bevacizumab, also we have evidence for starting Bevacizumab plus olaparib in maintenance. So these are the ASCO guidelines for management of ovarian cancer, olaparib maintenance. So SOLO 2 trial, which is a clinical evidence, it is a olaparib as placebo maintenance in patients with platinum sensitive relapsed high-grade CA ovary with BRCA1, BRCA2 mutation who had received more than 2 or equal to 2 prior lines of chemotherapy. So SOLO 2 trials, the median PFS analysis shows significantly improved median PFS by 13.6 months over placebo, with 70% lower the risk of disease or death. So the olaparib is continued for 300 milligram BD for 2 years. So the final analysis, so median OS is improved by 12.9 months with maintenance olaparib versus placebo, despite 38% of placebo patients receiving subsequent PARP inhibitor therapy. There is a crossover. So the time to subsequent therapy analysis, olaparib significantly extend the time to first and subsequent therapy. So the final safety analysis shows the important things. The MDS and AML is which is 2% when compared to placebo patients. So in SOLO 1 trial, olaparib versus placebo maintenance following platinum-based chemotherapy newly diagnosed. Here we are having a newly diagnosed patients with advanced ovarian cancer with BRCA1, BRCA2 mutations who has undergone a platinum-based doublet and achieved a CR or complete remission or partial remission. This is a SOLO 1 trial. It supports a maintenance therapy for olaparib for 2 years. So the median PFS analysis showed 4.8 median PFS of 4.47 years with olaparib and 1.2 years with placebo. So at 7 years, approximately 2/3 of patients, that is 67% of patients were alive with olaparib and 47 patients were alive with placebo. So time for subsequent therapy for it is more favorable time for subsequent therapy 64 months versus 15.1 months, as well as second subsequent therapy 93.2 months versus 40.7 months with maintenance olaparib versus placebo. So the risk of MDS here is also high in the olaparib arm in this trial. So Paolo on trial is a olaparib plus bevacizumab in first-line maintenance in newly diagnosed advanced ovarian cancer patients who has undergone a platinum-based doublet therapy and achieved a CR or PR. So there is 46.8 months, that is approximately 3.9 years median PFS with olaparib plus bevacizumab, and 17.6 months, 1.5 years with bevacizumab plus placebo. So 59% risk reduction of disease progression or death. So PS 5-year PFS comparison, and the PFS advantage was seen in HRD positive subset which excluded BRCA mutation, as well as in subsequent a subset with included which included only BRCA mutation. So this study shows the activity of olaparib in HRD positive patients and BRCA patients also. So on conclusion, olaparib displays clinical activity and is therefore up to us maintenance treatment for ovarian cancer starting from the first line as monotherapy in the BRCA mutant and combined with bevacizumab in HRD patients. Maintenance treatment in the platinum sensitive recurrent ovarian cancer independent from BRCA status. Thank you.
Thank you, Dr. What we need to do for advanced treatment naive ovarian carcinoma. May I now request Dr. Raja to have the treatment options available for recurrent ovarian carcinoma. Raja?
Yeah, good evening to all. And I thank Prasad for the opportunity and Lambok also. So can I have my slides, please? Ovarian cancer is known for resistance, we know, and this is the toughest time for the oncologist and for the patient also. It's very difficult to treat, and we have a few options to treat the relapsed ovarian cancer. Next slides, we see one by one. This is the overview. Epithelial ovarian cancer accounts for 90% of all ovarian cancer. Most of them are presented with the advanced stage. Primary standard of care involves cytoreductive surgery followed by platinum and taxane based therapy. What is the challenges? Despite of high initial response rates, 70 to 80% with the neoadjuvant therapy followed by surgery or surgery followed by adjuvant therapy, approximately 70% of patients will relapse within 3 years. And the recurrent disease is typically incurable, and we need to change our intention to prolong the survival and symptom control and quality of life maintenance. Next slide. The definition of a relapsed ovarian cancer. Relapsed is defined as objective evidence of a disease progression after complete or partial response to initial therapy. This is given by the GCIG, Gynecological Cancer Intergroup, either by radiographic evidence or clinical symptoms or by biochemical rise. Radiological evidence, we know more than increase in 20% of sum of diameter of the target lesion according to RECIST 1, and clinical symptoms like new onset of ascites, bowel obstruction, pain or mass in the abdomen, and deterioration in the performance status, and biochemical rise, that is CA125, progressive serial elevation of CA125 and doubling time, quicker doubling time. So this must be confirmed by subsequent 2 or 3 samples. So these are all the evidence for a relapse. Next. We can classify the recurrence of ovarian cancer according to the platinum-free interval. That is the main entity. Platinum-free interval is important to be measured, and either as a platinum refractory, that means progression occur on therapy itself, during the therapy itself, within 4 weeks or of the last dose also. So they have extremely poor prognosis and primary resistance to DNA damaging agents. So we need to go for a clinical trial or a non-platinum monotherapy. And second one is platinum resistant group. That means resistant occur within 6 months of the last platinum dose. They have a low response to platinum re-challenge, require alternate therapy, that is non-platinum chemotherapy with or without bevacizumab. And third one is partially platinum sensitive. That's in recurrence occur within 6 to 12 months of the last dose of platinum. Intermediate sensitive to platinum. So we can either re-challenge or non-platinum drugs can be given. Final one is platinum sensitive. This is good prognostic group, and this recurrence occur more than 12 months after the last dose of platinum. We can re-challenge again with the platinum doublet with or without bevacizumab, and PARP inhibition also can be given. So this is the classification of the recurrence pattern of ovarian cancer. Next slide. Risk factors for recurrence, either residual disease. The most significant modifiable prognostic factor is the residual disease. If it is more than 1 centimeter after primary debulking, we have a high chance for recurrence rate. And second one is initial stage. If it is stage 3, 4 at the time of diagnosis, the relapse rate is very high, 70% for stage 3, 4 when compared to 30% for early stage. Third one is histology. High-grade serous carcinoma is the most common subtype associated with recurrence despite of initial chemosensitivity. So the other molecular determinants are BRCA and HRD status. BRCA mutations or HRD predict better initial platinum sensitivity but also influences maintenance therapy efficacy. And CCNE1 amplification, presence of this also will give a poor outcome, often mutually exclusive with the BRCA. Next slide, please. The clinical presentation for a relapse tumor, we know the abdominal and GI manifestation may be, patient may have ascites, early satiety, bowel changes and bloating, and systemic and constitutional symptoms like fatigue, weight loss, pain in the abdomen, and urinary symptoms like frequency and urgency due to bladder compression. And acute clinical complication may occur, either bowel obstruction or pleural effusion or venous thromboembolism or hydronephrosis can occur. These are all the various spectrum of symptoms in the recurrent state. Next. How to diagnose this group? How to work up this group? Initial clinical evaluation followed by lab assessment like complete blood count and other renal and hepatic function. CA125 trend analysis is important. Even during the neoadjuvant therapy, the serial monitoring of CA125 and Kelly score will guide us the biology of the ovarian cancer, whether it's a platinum sensitive group or not, like that. And third one is diagnostic imaging, CT, abdomen, pelvis, or PET scan. And finally, biomarker reevaluation for targeted therapy selection. So, biomarker testing strategy is for PARP inhibition or immunotherapy or platinum sensitivity or a new drug administration like mirvetuximab. Next one. Imaging modalities. The CT chest, abdomen, pelvis is the standard of care. We can do as a primary modality. Frequency baseline and then every 2 to 3 months of therapy, optimal for assessing peritoneal implants more than 1 centimeter. If it is more than 1 centimeter, then we have to monitor with this imaging technology. Contrast enhanced might be preferable one. And MRI, superior soft tissue contrast for pelvic recurrence and involvement of rectosigmoid and liver lesions and brain metastasis. MRI is the best methodology, and FDG PET have a high sensitivity 94 to 97. When we combine with the CA125, the sensitivity goes up to 100%. So, but the peritoneal metastasis is not well visualized with the PET scan, and it's not routine for standard of surveillance. Next. Tumor marker CA125 in relapse setting. CA125 elevation precedes clinical or radiological relapse. Sometimes biomarker relapse can occur without any disease 3 to 5 months before the occurrence of the disease. And according to the MRC 05 or EO3C 555 and 555, early treatment based solely on rising CA125 did not improve overall survival. So we need to watch, we need to wait for the symptom or imaging evidence to start the treatment. Current SGO, ESMO consensus do not initiate chemotherapy based on CA125 alone rise unless patient have symptoms or an enrolled in a clinical trial or imaging wise evidence. So GCIG progression criteria, if the patient have elevated CA125 pre-treatment than normalized, increased more than equal to 2 times of the upper limit on 2 occasions, we can consider as a progression, and patient with CA125 that never normalized in the condition increased to more than equal to 2 times the nadir value on 2 occasions also considered as a progression. So the lead time is 3 to 5 months after the therapy, and predictive value of CA125 in assessing the recurrence is 70% in relapse setting. Next condition, next trial. The treatment principles goal is this very tough to manage this recurrent setting. That will be a nightmare for oncologist and to patient also. So our goal is to prolong survival or symptom control, quality of life, and delay the progression. So personalized factor, we need to check for BRCA mutation and HRD status and folate receptor alpha expression levels, and treatment-free interval to be calculated. This is very, very important criteria, prior PARP inhibition or bevacizumab exposure. Patient profile, ECOG, and other problems and toxicity should be considered before starting the treatment. And preferences, treatment logistics depends upon the patient preference also. Therapeutic strategy, either clinical trial or sequencing, single agent or double agent, and supportive care, novel therapies also can be considered. These are all the overview for the treatment principles. Next. Now, the first category, platinum sensitive recurrence. The standard of care is doublets treatment with the platinum, carboplatin with paclitaxel, or carbo with gemcitabine, or carbo with pegylated liposomal doxorubicin according to the established trials. We can consider adding bevacizumab along with this doublet, and we can go for the maintenance strategy even after completion of the treatment, either with bevacizumab or PARP along with PARP inhibition. So expected outcome in these settings, overall objective response rate will be 47 to 66% with platinum doublet when compared to 30% in single agent, and median PFS is 8 to 12 months, and overall survival can exceed 30 months in modern series, heavily influenced by multiple lines of therapy. Next. So this is the platinum sensitive recurrence. The combination chemotherapy regimen, we know the carboplatin paclitaxel standard 3-week regimen, ICON-4 or AGO over 2.2 trial. Overall benefit was found with a hazard ratio of 0.8, and so 2-year overall survival is 57 versus 50. And the next one important is carboplatin plus gem, according to Ocean trial with bevacizumab or AGO over 2.5. Here also the PFS is very good when combined with the Ocean bevacizumab, according to Ocean trial. And third one is carbo and PLD. According to Calypso trial, the PFS is 11.3 versus 9.4, and overall survival is non-inferior when compared to other regimens. So these are important landmark trials in the doublet combination. Next. PARP inhibition and platinum sensitivity. So PARP inhibitors maintain significant prolonged PFS in platinum sensitive recurrent ovarian cancer compared to placebo. Benefit observed across multi-molecular other subtypes like HRD positive, BRCA mutated, or either whatever the combination. But greatest magnitude are seen in BRCA mutated and HRD positive populations. Recent long-term follow-up data shows a very good PFS benefit, and overall survival also have a higher in the rate. The evidence are SOLO2 trial and NOVA trial. In SOLO2 trial, 19.1 month PFS benefit when compared to placebo. In NOVA trial, it is 15.5 months PFS benefit when compared to placebo for niraparib. Next trial. Bevacizumab in platinum sensitive disease. We can consider in adding the bevacizumab along with the doublet. What is the benefit? This is according to the Ocean trial. When we combine gem carbo with placebo, 12.4 months of median PFS and 8.4 months of when compared to 8.4 months of median PFS in placebo, and 79% response rate. So it's better to add bevacizumab in the platinum sensitive group in recurrent setting. Next. The treatment algorithm when the platinum sensitive.
Sorry to disturb you, sir. Lack of time, kindly conclude.
Yeah, okay. Platinum sensitive recurrence, we have doublet therapy along with bevacizumab, with or without bevacizumab, and PARP inhibitions. Next. In resistant group, a single agent is preferred than doublet, either weekly pacli or PLD or topotecan or gemcitabine. Next. So this is the evidence of bevacizumab in platinum resistant disease, earlier trial, and which has a moderate response rate. The median survey PFS is 6.7 versus 3.4. Next. Immunotherapy approaches are there, but most of them are failed trial. Now recently we have pembrolizumab and nab-paclitaxel have a good response rate. And if it is biomarker driven, MSI high or DMMR will have a good response. And combination strategies are ongoing along with PARP or bevacizumab and chemotherapy. Next. Surgical management, we know the secondary cytoreduction according to desktop 3 trial will have a survival benefit if we treat with doublet therapy and followed by secondary cytoreduction. The survival benefit is there. Next. And treatment response monitoring, we need to assess clinically and imaging wise and CA125 also. So we should strictly monitor the disease. Either we have a CR, PR or stable disease or progressive disease. Next. And prognosis for platinum sensitive group, according to Ocean trial, will have a good median PFS and overall survival also very good. And in the case of platinum sensitivity maintenance, olaparib maintenance, and in case of platinum resistant recurrence, combination with the bevacizumab with chemo will give some modest benefit. In platinum resistant group, we can go with newer drugs like mirvetuximab or folate receptor alpha antagonist. Next. So these are the evidences for my study. Thank you. Prasad, conclude.
Dr. Prasad, please
Yeah,
unmute.
sorry. Yeah. Thank you so much for the insightful presentation on recurrent ovarian carcinoma. Thank you, Dr. Yeah, it's more like in a resident disease, we need to have a more of a molecular pathway-driven treatment for overall survival for our patients beyond the standard lines of chemotherapy. We understood that. Thank you so much. If there's any doubts, we could have the question and answer session. Any clarifications from the postgraduates? So this talk is over. You can take off the screen. Yeah. So if there's no further questions to the presenters, may we conclude the session?
Yeah.
Thank you so much, Dr. Jayant, Dr. Mukham, Dr. Prasanna Pandidurai, and Dr. Raja, for and the time that you had spared to help us brush up with all the newer updates on breast and ovarian carcinoma, and quite an innovative and interesting introduction to CTC and ctDNA given by Dr. Jayant and subsequently by Dr. Aramugam sir also. Thank you, Glenmark, for the insightful evening, and thank you so much for all the organizers and sponsors. Shall we conclude the session?
Thank you very much, Prasad.
Yeah, thank you, Prasad.
Thank you so
Thank you,
much.
sir.
Good night.
Thank you. Thank you very much, sir.
Yeah, thank you.
Thank you, sir. Yeah, Shakshi, we can close it.
Okay, sir. Can we close?
Yeah, please.
Okay, sir.
Thank you. Thank you very much.